62-year-old Hispanic male, 6-month history of worsening dyspnea, non-productive cough. He had smoked for a number of years, quit 5 years ago. Really didn't have any occupational exposures in his history to suggest that that was contributing. You look at his fingers and they're like clubbed, right? Looks like a cartoon character. His fingers are so big at the end. His chest x-ray and his chest CT are abnormal, and this is what his chest CT looks like. What is the next gold standard for the next diagnostic test? Is it to do a bronch? Is it to do a lung biopsy? Is it to get some pulmonary function tests? Or is it to do the CT again, but this time with contrast? All right, pulmonary function test. It's actually not the right answer. The right answer is lung biopsy. So we'll get a little bit to the imaging here. We'll go back to the imaging and I'll show you why. So idiopathic interstitial pneumonia, again, one of the categories of the interstitial lung disease. The clinical feature of this insidious dry cough, exertional dyspnea, it happens more often in men than in women, and it kind of manifests itself typically in the 5th to 7th generation of life. You get crackles, oftentimes you see clubbing, meaning that he's had hypoxia for a long period of time that it just wasn't recognized. So his oxygen saturations have been deficient for longer than what he probably was aware. The chest x-ray shows progressive fibrosis, and the chest CT shows honeycombing, which is what the CT showed, and I'll kind of show you that in a little bit of a different way. The PFTs will show a restrictive pattern, but oftentimes the only way to actually make the diagnosis is surgical lung biopsy. There are some people that choose not to do the surgical lung biopsy, and then you don't really truly know, but you try to treat them the best of the ability based on their clinical picture and then their history. So this is what honeycombing looks like, and for those that work in practice already, I'm sure you've probably seen this reference made in CT reports, but as you can see now, like this is what the honeycomb looks like. Yeah? Yeah. So this is honeycombing, and this is very pathognomonic for UIP, usual interstitial pneumonitis. Why is that important? Because this is the worst type of ILD to have. There's really no treatment cure, and the life expectancy once you're diagnosed with this is about 3 years. The only treatment option is transplant. We'll get a little bit more into that. They're trying some meds. Yeah. So again, IIP is the most common type of interstitial lung disease, and UIP has the poorest prognosis. NSIP, on the other hand, has a very good steroid response, and so if the biopsy shows that it's NSIP, you could treat with steroids and possibly improve. Again, for IIP, specifically UIP, there's no proven treatment. You can consider steroids, but again, oftentimes they do not help. There's some immunomodulators, azathioprine, cyclophosphamide. I think Rituxan is now in that category as well. There's some new drugs, pirfenidone and nintedanib, which are tremendously expensive and have kind of mixed reviews. And again, the mean survival after diagnosis is 3 years, and the only treatment option is transplant. We actually have a couple of patients currently in our unit that are awaiting lung transplantation on high-flow oxygen. And again, other than trying to maintain them while they're waiting for lung transplant, that's really what we do, and hope that they get some lungs.